Dr. Raja Sabapati, Managing Trustee from ISSH Association, Dr. Raja Indra Nehete, and the Dr. Anil Bhatt, Secretary and Treasurer of ISSH Association, to come on the dais, please. I now request Dr. Raja Sabapati to introduce the Emperor Ashoka Awardee for Excellence in Hand Surgery to the audience. Thank you.
Good evening to all of you. Our, our association has grown from strength to strength, and one of the important events that has occurred in the growth of our association is the institution of the Emperor Ashoka Award. This was instituted 3 years ago by the idea of the initiative of Dr. Somesh Guha, an Indian plastic surgeon who is settled in the United States. It was conceived with the idea that every year one hand surgeon who has done considerable amount of work and has stood for excellence and has pushed the boundaries in that particular field be honored by this oration. Last year we had Dr. Michael Tonkin in the field of congenital hand surgery, and this year we are very proud to have Dr. Caroline Leclercq from France to deliver this oration. So it has been a novel idea that has come up, and all of us will benefit from this oration. May I now request our Secretary, Dr. Anil Bhatt, to introduce the orator.
Good evening, everyone. Caroline Leclercq is a senior hand surgeon at the Institut de Lemaire, which is in Paris, of which she is the current president, after Raoul Tubiana and Aline Gilbert. Former president of the French Society for Surgery of the Hand and member of the French Académie de Chirurgie. She is also a honorary member of the BSSH and the ASSH and member of the Hellenic, Italian and Colombian Societies for Surgeries of the Hand. Her main subspecialty is neuroorthopedics of the upper limb, especially in the fields of tetraplegia and spasticity. She organizes yearly master classes on the treatment of spastic upper limb and is a consultant in 10 neurological rehabilitation centers of both adult and children. Her current clinical research involves nerve procedures in the treatment of spasticity. Her other fields of interest, besides paralytic and spastic upper limb, are Dupuytren's disease, sports injuries, and hand tumors. She is the author of 7 books and more than 100 scientific articles and book chapters, and has presented more than 70 oral presentations at national and international society meetings. She is heavily involved in postgraduate teaching, both nationally and internationally. She was the assistant editor of the European Journal of Hand Surgery for 9 years and is a member of the FESH Education Committee. I now request our president, Dr. Rajendra Nehete, and Dr. Raja Sabapati, our managing trustee, to hand over the medal to Dr. Caroline Leclercq.
Well, thank you so much. It's a great honor to be here today and to deliver the Emperor Ashoka, I had to learn this name, oration. Where do I come from? This has been introduced already. Institut de la Main under Professor Tubiana and Professor Gilbert. Actually, next year we're going to celebrate our 40th anniversary. We're going to have a big meeting. You're all welcome to come. It should be a lot of fun. So there's 13 hand and upper limb surgeons in our group. We do clinical work, teaching, research, and we also have an international fellowship program. So how about this Emperor Ashoka? From the little research I did, he's obviously extremely important in your country, in the culture, and in the everyday life of your country, because his chakra is represented even on your flag. He seems to have had several stages in his life, as reflected by the names he was given. First, Kamashoka, the man of pleasures, and then he became a leader, and he became the emperor, did a little of killing, especially among his siblings, in order to settle his empireship, fearful battles, and then finally decided that this was not a good way of doing it, and converted to Buddhism, became a peaceful man, vegetarian, and successfully conquered this huge territory. So I was reflecting that maybe this is an example we should give to our current leaders in this very troubled world we're living in. So spasticity. Who has no idea about spasticity in the room? Or very little? Ah, fantastic, so that's going to be easy. So we define it, like Lance did, as an increase of the muscle tone, reflected by the increase of the stretch reflex. And this goes along with exaggerated reflexes. The difficulty is that there are many, many forms of spasticity, especially in the upper limb. And you're going to see that the clinical presentation is extremely varied and complex. The proximal part of the arm is most often in adduction and internal rotation, elbow inflection, wrist inflection, pronation, and in children sometimes ulnar deviation. But we also see some spasticity in elbow extension and wrist extension. For the fingers, it defies every description. You can have all these pictures that are due to spasticity. So it's quite difficult, and the thumb, I'm sorry, the thumb is usually in adduction and very often representing the mixed type. So the one thing that has been helpful when we started with this surgery is to understand what is the cause of the deformity. Why does the arm goes into flexion? Why does the finger go in flexion? And so forth. And there are several components to this deformity. The first one, obviously, is spasticity. We know its characteristics. It's going to resist passive stretching, but eventually yield, but slowly come back to the same position. It is one element of the deformity, but only one, and it needs to be treated as such. But there is also muscle contracture, usually a consequence of spasticity. It involves the same muscles, but as opposed to spasticity, it's permanent. You cannot fight it. And it does not require the same treatment. So we must absolutely distinguish the two. Then there is joint deformity, again a consequence of the spasticity. Can be stiffness, especially in adults with stroke, and it can, on the other hand, be hyperlaxity, as you can see here in children. And then finally, and again, another consequence of spasticity is motor imbalance. Those muscles which are not spastic are going over the years to become paralyzed. So usually spastic muscles are active, non-spastic muscles are paralyzed or pseudo-paralyzed because they are prevented from working, and all this is quite difficult to assess. Clinical examination is critical for the success of the treatment. And we have to repeat it. We try to do it as much as possible as a team examination with physiatrists, neurologists, physiotherapists, occupational therapists. We have standardized charts, and we do a lot of video recording per and post-operatively, especially in children. Botulinum toxin is a tool that's extremely helpful for us, not only in distinguishing spasticity itself from muscle contracture, but also after the botulinum toxin has been injected, we can reinforce the antagonist, so-called paralyzed muscle. It allows also to assess some other groups, namely the interossei, which are extremely difficult to assess when you have a closed fist, and to some extent is going to mimic the results of surgery. So as I said, we need to address all three components. We need to reduce spasticity. We need to release muscle contractures. We need to reinforce those muscles which are paralyzed. So this is obviously going to be a multiple procedures surgery. So where do we stand? Where did we stand a few years ago? Well, classically, there was not much that was done for spasticity surgically. There was medical treatment. We would occasionally do a neurotomy, which is total cut of the motor nerve, but obviously then the muscle was paralyzed. For muscle contracture, we had, and this is the types of treatment that we used in the past for spasticity. Besides medication, splints, physiotherapy, electrostimulation, the only things that were actually working in a clear manner were nerve blocks and botulinum toxin, but we all know that they are temporary and need to be repeated very often. Muscle contractures, there is a number of procedures, I won't go into the details of that allow to release the muscle contracture. Let us remember that there is proximal release with muscle slide, only of the wrist flexor or wrist flexors and finger flexors, the so-called Scaglietti-Page operation. And because of the side effects of this surgery and the difficulties, it is seldom performed anymore. We prefer to do fractional lengthening every time it is possible, meaning if there is enough overlapping between the muscle and the tendon, and if that's impossible, the lengthening of the tendons. There is one surgery which is quite effective in non-functional hand, referred to as the STP, transfer of superficialis to profondi. In some extremely bent wrist, we are likely to offer to the patient a shortening wrist arthrodesis. Third procedure is reinforcing voluntary control, and that's mainly tendon transfers. That is a problem because not many muscles are available for tendon transfer. A few of the spastic muscles can be used if they have voluntary control and ability to relax, and that depends on dynamic EMG. So the tendon transfer which we're going to choose is going to be custom-made depending on that. This is a result here of a tendon transfer, sorry about this, tendon transfer of the brachioradialis to the wrist extensors in a 12-year-old boy. So what has changed? Well, these procedures which I just described did not prevent recurrence of spasticity, and a number of them were not satisfying because of this. And the accent has been put by several of us on the nerve procedures. And this is what I'm going to be describing for a few minutes. There is one new non-operative treatment, which is cryoneurolysis, and the nerve is directly lesioned by direct contact with an ice ball. This comes to us from Canada, Paul Winston namely, and they have shown quite interesting results with this technique, which is percutaneous. The problem is that with axon and myelin disruption of and whatever degeneration of the nerve. The problem is we are not sure if how this will be effective in the long term. So I think we need to wait for a few more months or years in order to understand. So what is the surgical treatment that we have to offer nowadays for spasticity? Well, there are mainly three of them: neurosurgical ablative procedures, contralateral C7 root transfer, and selective and hyperselective neurectomy. We need to understand that this nerve treatment will reduce spasticity and spasticity only. The goal is to keep useful muscle tone. We don't want to do neurotomy and have the muscle paralyzed. And it is only effective on spasticity and not on contracture. If there is associated contracture, we need to add some of the procedures we've described before. So the so-called dresotomy, DRES standing for dorsal root entry zone, consists in lesioning the cervical spine and the dorsal rootless right at the contact of the spine with coagulation or radiofrequency. This has been, a lot of work has been done on this by a French team, namely Dr. Sindou, who was a neurosurgeon, and it's mostly performed for the lower limb. It's not very reliable, and then it's more dangerous for the upper limb, and so it's not a solution for us. A very interesting second solution comes with the contralateral C7 root transfer. Of course, all of us know here about the use of contralateral C7 in brachial plexus, and this has been done with many teams with very interesting results. But the first case of its use in spastic coupling was done by Dr. Xu from Shanghai, and in 2018 they published a randomized trial in the New England Journal of Medicine. So we all know that there is no donor side effect, and the authors reported positive outcome with functional improvements, and surprisingly in patients who were more than 15 years from their stroke. This procedure raises a number of questions. First, the C7 territory is more the territory of abduction, extension, supination, opening of the hand, and we're trying to reduce spasticity of more or less the opposing muscles. So is that going to be effective? We don't know. Will it improve the grasp? We don't know. And then it has been questioned if it is the transfer of the root which is effective, or maybe if it's just cutting the ipsilateral C7 root that does the job. And there is currently a large international study addressing this, and I hope we'll have the results very shortly. The third procedure, nerve procedures that we have been using, and I've done a lot of work in the past 15 years in that procedure, is the so-called selective neurotomy or neurectomy. It doesn't make much difference. So it's not complete. It is called selective when we do partial resection of the motor branch of any muscle, regardless of where it is performed, and we call it hyperselective when the section is done at the very distal end of the nerve when it enters the muscle. Let's remember that it is only effective on spasticity, and if there is associated contracture, that also needs to be treated. So this is a truncular technique where the nerve is partially cut at the level of the motor nerve itself. That requires, of course, electrical stimulation to know what needs to be cut, and there part of the motor fascicles are cut. The main advantage of this technique is that it allows a limited approach to the nerve. The problem is that it only relies on electrical parameters, and we all know that there's a lot of variations in the anatomy of the motor branches. So it may miss part of the branches, and it may also injure some sensory branches if they get cut together with motor ones. And here is hyperselective neurectomy, as you can see here in this very nice drawing by Mikalev, where the nerve is partially cut when it reaches the muscle at the very tip of the motor nerve when it divides in several little branches. This was put forward by Brunelli, Italian surgeon, in 1983. And after some trial, he said, well, we should cut at least 2/3 of the fascicles when they reach the motor nerve. Otherwise, this is not going to be effective, and there might be some recurrence. You can see here, I don't know if that's showing. You can see here how the branch of the median nerve to the FCR divides in those nice little branches that reach the muscle, and here we cut approximately 2/3 of the branches. This is much more selective than the previous one. There can't be any mistake. We cannot have sensory disturbance, and we can also cut a little more if we feel this is needed. I'm not going to go into the details of the anatomy, but before starting this experience, we did a very large mapping of all the motor branches of the upper limb muscles. And let me show you just what we found on the musculocutaneous, for instance. And you see here that for the biceps, there was this one big branch, in this case, dividing right away in 3 branches. There was a second branch later, I'm sorry. And the brachialis received 3 branches here before the sensory nerve went away from the brachialis. So that tells us that here a truncular neurectomy would indeed be difficult and may not be as selective as we want. This is just an example. There are many other ones. For the median nerve, things are even more complicated. The one problem with the median nerve is the branches to the flexor superficialis and profundi of the fingers. It's impossible to reach those branches without detaching completely the pronator teres and the flexor superficialis, which has been done here on that slide. And you can see all those tiny branches. The other thing is that those branches take their origin very high and very low, and we would really have to do a lot of dissection and harming the muscles if we want to apply this technique to the finger flexors, which is why we do not for the moment. We're trying to find other ways, but so far we haven't been able to apply it to the finger flexors. This is our dissections for ulnar nerve, radial nerve. We can even now do it for the thumb intrinsex. This is quite easy to do. Surgery is performed usually under general anesthesia. That's mostly for the comfort of the patients. We can use a tourniquet, but we need to remember that nerve stimulation will only be effective for 45 to 50 minutes, so we have to dissect our branches quite fast. So the hyperselective neurectomy, as said before, is done as close as possible to the neuromuscular junction. no postoperative immobilization unless there have been some associated procedures for contracture, immediate rehabilitation, tonification of the antagonist muscle, and then progressive reinforcement of the operated muscles. This is briefly the results of this prospective study that we published in 2021, 42 patients, isolated spasticity, no contracture in this group, 101 muscle, and they were followed at 6 months and 30 months in the initial paper. This is our assessment. I don't have time to go into that, but the Ashworth scale is not enough to assess spasticity. We use also the Tardieu scale, and this is, I think, very important if we want to have results that we can quantify enough. These are the results for the elbows. The results for the other joints were exactly the same. All the figures in red were significant. You see that the spontaneous posture was significantly improved. The active and passive motion were not, but that's because there was no contracture. And probably the most satisfying outcome here is that the strength of the muscles that were partially neurotomized did not decrease at all. They kept the same strength at 30 months, and even at 6 months it was already back, so it did not decrease the muscle strength. The 3 markers of spasticity, Ashworth and Tardieu, were significantly improved, both at 6 months and at 30 months. The extensor, the strength of the extensor was not much changed at 30 months. The functional scale by House was significantly improved. This is one result of a 16-year-old CP cerebral palsy patient. And you see after hyperselective neurectomy of elbow flexors and wrist flexors, he has no spasticity anymore in these muscles. At the follow-up of 30 months, 30.6 months, we witnessed that there was early on, in the first few months, a little bit of relapse of the spasticity, as shown by Ashworth and Tardieu scales, but then after it was stable. Patient satisfaction was high, and the goals of surgery were reached in 92% of the patients. We were a little worried about this little relapse of spasticity, and we conducted a second study, which should be published shortly, with Dr. Chung, who is in the room here today with us. And we were very reassured that after a follow-up of 53 months, there was no change in the spasticity. It did not recur again. And on the opposite, there was some improvement in the strength of the antagonist extensors, and there were even more diminution of the Ashworth and the Tardieu scale. Mode of action of this technique, well, it was based mostly on clinical experience when we started, and but with the help of some research colleagues, we started to understand a little more on what we were doing and why the spasticity did not recur. To understand that, we need to remember that the motor fibers per se do have a sensory component inside themselves, and this sensory component is not for the cutaneous part, but it's more for the muscle spindles and the nociceptive and vegetative receptors. So we have alpha and gamma motor fibers, and mostly 1A sensory fibers, which are involved in that. And those slides out to our friend Dr. Sami Toufa, showing the reflex arc with when the reflex is performed, the sensory A1 bringing the reflex into the cervical spine, and then the reflex arc going back with a muscle twitch into the muscle. And this is mostly directed by the alpha here and the gamma here fibers. But there are those sensory fibers, which are those involved in the spasticity. And whereas the motor fibers per se do have the capacity of regrowth, and we've known that for many, many years, the afferent axons from the A1 fibers do not have a capacity to regrow, which is why spasticity does not recur. My friend Sami Toufa tells me that it is not as easy as what I'm telling you. So it's probably much more involved. And we have seen some interactions with the lower limb when we do hyperselective neurectomy in the upper limb. And we have also seen some interactions between the two hemispheres with some improvements in a few cases of upper motor function, which sounds like something really strange after cutting a few motor fibers. Just to finish, if I have a few more minutes, a few cases. This is hyperselective neurectomy of the pronator teres in a cerebral palsy young woman. She had other things, but I just want to show you her pre-op evaluation. You see that she has a lot of spasticity in the pronator. And this is her again at 8 months post-surgery. And you see that spasticity has completely disappeared. Another case, remembering that if there is spasticity and contracture, both need to be treated at the same time. This is again a cerebral palsy patient, but he's an adult, 32 years old. He hasn't been treated. He has a lot of spasticity and contracture in his elbow flexors. And although he has a little bit of hand function, he has no way of using it because of the elbow. And you see here the tardio showing you that part of this is spasticity and part of it is contracture. So we did at the same time hyperselective neurectomy of the musculocutaneous nerve and lengthening of the biceps and the brachialis muscles. And this is the result at 20 months post-surgery. His spontaneous posture went from 100 to 40. His active extension improved from 60 to 50 and passively from 70 to 40. He has no more spasticity in the elbow flexors. He's extremely satisfied. He was so satisfied that he asked for further surgery to the hand. And you see him here after he had wrist arthrodesis. And finally, a third case, it's again a cerebral palsy with a left hemiparesia. She's an 11-year-old girl. She has a very weak left upper limb, and this is her performing what is known as a box and block test. And you see that she has very little function in that left upper limb. When we analyze her deformity, she has spasticity of the wrist flexors, but it's not extremely great. She has no active extension of the wrist, and that's important to note. And she has weak finger flexion and extension, no muscle contracture. She also has mild spasticity and mild contracture of the thumb, which was treated at the same time. So we used botulinum toxin in her case for the wrist flexors. Spasticity disappeared, and the wrist extensors, the antagonists, went from a 0 to a 3 in the MRC grading, which improved her grasp a little bit. We had no way of improving by tendon or nerve transfers her wrist extension because all of her muscles were so weak. So we decided to go on and do hyperselective neurectomy of the wrist flexors and see how much she would improve, and at the same time treated the thumb. And this is her at 3 years follow-up. And you will see the box and blocks test before and after 3 years. And we were very happy to see that her wrist flexors went all the way to a 4+. So they were, no, I'm sorry. The wrist flexors remain at the same strength, sorry for that, but we were very happy to see that the wrist extensors went from a 0 to a 4+. So by just relieving spasticity, no muscle or nerve transfers, we were able to gain that wrist extension, which of course gave rise to much better finger flexion and extension. She had a tremendous functional improvement, could dress independently, open doors, cut meat, use a ruler and pen, do bicycles. She's very involved in sports and says she can even dribble with her left hand. This has also, and we've seen that in a number of cases, improved the adjacent joints, and she has less spasticity in her elbow flexors and improved elbow extensors. So that's where we stand, and we feel there is much more to it. And we are, as I said, some teams are engaged in looking at C7 neurotomy, only neurotomy on the ipsilateral side. And we are now thinking, and we have started to do this, but it's much too early to publish our results, started to do section suture of the nerves to the spastic muscles, thinking that if the spasticity doesn't have the capacity to recur, well, maybe we can do that at a higher level. This is just steps for research. We will have a very interesting meeting in May in Barcelona that's going to be only dedicated to nerve procedures in spasticity, and probably we will start to have some of the answers. So again, you know, as a conclusion, spasticity does need to be addressed in the surgical treatment. We need to use nerve procedures, and we do now have some tools that help us, and namely, for what I'm concerned, hyperselective neurectomy. We still have a problem with finger flexors. There is a little relapse of spasticity early on, but now we're quite confident that then it is stable. This is not an easy surgery. This is not an easy field of surgery, and you've seen that clinical examination and decision-making is and remains the most important part of it. For those who are interested, this is the master classes that we run twice a year in Budapest in November and in April. Thank you very much for listening to me.
Thank you, ma'am, for such illustrative talk. And ISSH identifies the gap between the clinical patients which are available and the treatment being given in India. And at present, we have very few surgeons who have ventured into the spastic upper limb. And I know your talk will stimulate many young surgeons to opt for this field. We have a lot of patients in this because of the head injuries and the spastic and the stroke. So I know the younger generation will take this field and go ahead. Thank you very much for coming. And we usually prefer a person from the world who is venturing into the new topic and pushing the boundaries of that by research and clinical work. And thank you for coming here and delivering this talk.
Thank you so much.
Thank you, Dr. Caroline Leclercq. We are indeed mesmerized and honored by your presence. And I would also like to thank all the delegates who were a part of this session. While we await for the arrival of our esteemed chief guest, let's enjoy some enlightening entertainment.
Ladies and gentlemen, now to make this evening even more memorable, we invite you to sit back, relax, and enjoy the cultural program we have arranged for you.
Namaste. Good evening, everyone. Today we'll be performing we'll be doing three performances for you all. The first one will be on Lord Shiva. So Shiva, we will be showing the different forms of Shiva and the different bhavas and everything, the different emotions and all. So Bharatanatyam, it comes from the southern part of Bharat, and this is a beautiful art form which is being performed all over the world today, and we are really grateful and thankful to be able to perform this one for you all. Thank you.
Om Namah Shivaya, Shivaya Namaha. Mahadeva Shiva Shambhu. Mahadeva Shiva Shambhu. Shri Mahadeva Shiva Shambhu. Shri Mahadeva Shiva Shambhu. Shri Mahadeva Shiva Shambhu. Shri Mahadeva Shiva Shambhu. शिव शम्भो
धीं धीं तक्क दिम्मि दिम्मि तद्दिम्मि तद्दिम्मि तरिकिड तरिकिड तत्तिम्मि तरि तरिकिड तक
सहस्रकोटि जनपालना सहस्रकोटि जनपालना साधु संरक्षणा पावन साधु संरक्षणा पावन
कटवर मुनि जन सकल सुरा सुर सन्नुत पाद किं किण्णि झम झम जन 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 नूपुर लय गति कण 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 विधि हरि सेवित
साधु संरक्षणा पावन साधु संरक्षणा पावन महादेव शिव शम्भो सर्वेश्वर करुणाकरमूर्ते सर्वेश्वर करुणाकरमूर्ते सामगान प्रिय वेदस्फूर्ते सर्वेश्वर करुणाकरमूर्ते
कुडु तक तरिकिड तक ताम तक 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 तरिकिड तक तक तांडवि दंबर दिक तक तक तिरिकिड तक तक व्या झज्जर मधर तुंक तक तक तणक तक तक त्रिशूलधर नंक तक तक ननक तक तक नंदि वाहन नाद योग प्रिय
सामगान प्रिय वेद स्फूर्ते परमेश्वर गंगाधर कीर्ते परमेश्वर गंगाधर कीर्ते
जगनंकिड तक तुक तक 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 ताम जक जक जय जय शशि रवि भूषित
परमेश्वर गंगाधर कीर्ते पतित पावन श्री पशुपते पतित पावन श्री पशुपते
धीम 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 रूप भयंकर डमरुग हस्त तृतीय सहस सदीक्षित नाकनटे शकवृत्वं तकतकतं तकतकतै तक्कोधिक कोदा किट्ट तुंगटकटतगिडं तुंगटकटतगिडं किन्नं किटतकदिक्कुत्तां तक्तां
पतित पावन श्री पशुपते पतित पावन श्री पशुपते पतित पावन श्री पशुपते महादेव शिव शम्भो शिव शम्भो शिव शम्भो